Okay, Assalamu alaikum wa rahmatullahi wa barakatuh, everyone. I'm Abdulrahman Farahat. I'm a third year medical student, and today I'm delighted to be giving the psychiatry crash course. Inshallah, it's going to be a simple, really quick, short crash course to sort of gather all the info into one. Here's my contact number. If you have any questions, please feel free to text me anytime you want, and we shall begin. Right, so for this part of the crash course, we're going to be covering the first 7 lectures, inshallah. The first 2 are very basic, and I might be going a little quickly through them. So if I am, please tell me if you want me to slow down. However, they are really basic lectures, and inshallah, they won't take time. The rest, we're going to have our discussions in, inshallah. So, starting with Introduction to Psychiatry. For me, this lecture is basically some sort of anatomy and explaining basic concepts that are going to be spoken about in more details in the next lectures. But I covered only the main points in this lecture. So starting with the brain, we all know the brain, we divided it into 3 sections. The survival brain, which is in the brain stem, the limbic brain, which is over here, and finally the prefrontal cortex or the frontal lobe, the thinking brain. So for the survival brain, as we know, it's responsible for your basic needs for survival, like breathing, and it's the brain that's shared with animals, okay? Then the limbic brain and frontal lobe, we're going to speak about into more details. And then you have how the brain develops. It develops from down to up and from back to the front. طيب. Sorry. Okay, like from back to up and back, and then from front back. Oh, from down to up and then front back to front. Okay, and then you have. Let's take a look at the limbic brain. Now, the limbic brain, we have 2 parts of it. We have the amygdala and the hippocampus. So the amygdala is responsible for, as we all know, the emotional aspect, and the hippocampus would be for your memory. What's the amygdala doing? When it gets stimulated, it activates the HPA axis, and you guys should know the deal about this. Moving on. Yeah, this is where it's located. This is a small concept covered by the doctor. Does anyone know why is it hard to forget the memory of a loved one? Again, this is more into the hippocampus.
Because there is much better connections in the hippocampus.
There would be a better connection. Yeah, so generally in a memory of a loved one would cause the neurons in your brain to have a lot of, the dendrites would be thicker and they'd have multiple connections, like you said. And so it would be hard for you to forget them. And this is why, and some of those neurons are dopaminergic neurons. And so if you do forget or you lose that person, these neurons won't release any dopamine anymore. And that's why a person, when they lose a loved one, they could feel sad, angry, they would be demotivated all the time because they're losing a good aspect of their dopamine. So this picture basically depicts what's the difference between a limbic system of a male and a female. As you can see, the male has, which one is more complex? Male or female?
Female.
Females are more complex. There are 2 reasons for that. A reason in the female and a reason in the male. Why do you think, or what's the reason for females being more complex? Because they take care of other people. And for men, because there is testosterone. And testosterone basically because of the limbic system over here. So now, this is the basic part of the limbic system. Now, before we go into the frontal lobe or the thinking brain, the one that controls your limbic system, we need to take a look at some relay stations here and there. First, we're starting with the thalamus. So the thalamus is important because it's, like we said, it's a relay station. So all the neurons of your brain, they come to the thalamus, and then they disperse to your frontal lobe or wherever they are destined. So that's the function of the thalamus, basic stuff. Then you'd have the hypothalamus. What's the importance of the hypothalamus? I need you guys to remember 2 main functions. Vegetative symptoms, it controls your vegetative symptoms. So vegetative symptoms is anything like your appetite, your sleeping habits, or anything that maintains basic life. And it's also important for the HPA axis, hypothalamic pituitary adrenal axis. And as we know, it releases norepinephrine and cortisol. A question, too much norepinephrine could cause what? What condition? There's a comorbidity associated with too much norepinephrine. Okay, so that would be hypertension. And if there's too much cortisone, that would lead to diabetes. Okay, moving on to the frontal lobe. So for the frontal lobe, we divided it into two parts, the dorsolateral prefrontal cortex and the orbitofrontal cortex. What are the functions of each? Dorsolateral prefrontal cortex, why is it important? It's important for your decision-making, your prioritization of stuff, and your thinking. So your thinking memory, your working memory is all in the dorsolateral prefrontal cortex. Then you have the orbitofrontal cortex. The orbitofrontal cortex is what makes you feel
reasoning and not irritable.
Yes, exactly. So not irritable, you're calm, you're not angry all the time. What strengthens your orbitofrontal cortex?
Good childhood.
A good childhood, but there's an important thing you need to remember is a good connection with the mother. Do not forget that an orbitofrontal cortex develops when you have a good connection with your mother. And other stuff that could damage your orbitofrontal cortex are alcohols and drugs, okay? And this is why people who are on like drug addicts and so on, they are irritable and angry all the time because their orbitofrontal cortex is not working anymore. So this is basically done with the first lecture because there isn't much in it to say, and as I said, the rest of the stuff would be mentioned in other lectures, inshallah. So let's move on to quick questions really quickly. Which area of the brain is involved in impulsive disorders? A, B, or C?
A.
A. Okay. And next question. Emotional memory is mainly stored in?
Amygdala.
Yeah, the amygdala, because emotions. So this was for the first lecture. Now onto psychiatric interviews. Now this lecture is a little all over the place because there isn't particular organization to it. However, I tried to organize it into a 7-point scheme that if you could remember, inshallah, yani, you could have like a plan in mind when you're doing this. So before we get into that 7-point scheme, let's look at the goal of psychiatric interview. Remember this. It's important to know that a psychiatric interview is there to help find out what's inside the patient's limbic system. Because the saying or the statement the doctor said was, feelings are byproducts of your emotions, and feelings come from your frontal lobe, and they are byproducts of the emotions that are deep inside your limbic system. So the whole purpose of a psychiatric interview is to find out what's inside this patient's limbic system. Might seem very complicated right now, but we're gonna make it easy. Let's take a look at the basics of the interview process. Remember, really simple stuff. First, you introduce yourself to the patient, then you put the patient at ease. Now, it's really important to not forget this one because remember, you're dealing with psychiatric disorders. You might be dealing with an anxiety patient and they could be tense. You need to make sure that this patient is at ease. Now, 4 things you could remember, you could try to remember on how to put a patient at ease. طبعا, you need to offer them a seat. Should be not judgmental when they're speaking to you. You should avoid excessive note taking. And finally, you need to observe their nonverbal cues or behaviors. But that's putting the patient at ease. Is it that important? Not really, صراحة, you won't probably get asked about. Then you have history taking. History taking, again, really simple, pro stuff. You get the history of presenting illness, you ask past history. Now, important to remember, in past history, you ask about past psychiatric conditions. So if a patient comes to you and this patient tells you, well, I'm feeling down, you need to check if those patients, you're thinking of depression. So you need to check if those patients had a previous history of depression or not. Then طبعا, you ask about family history, social history, and really important to not forget childhood. Childhood trauma and childhood history in general is very important to diagnose those diseases. Then you have something I compiled all together into one, is the interview techniques. So for interview techniques, try to remember 4 main things. First, Open or close-ended questions?
Open.
Open-ended questions. Then second, you need to avoid leading questions. So what are leading questions? Leading questions is when you ask the patient a question and you expect, or you word the question in a way where you're expecting the answer from the patient. But the example given, or an example I had in mind, is when for example, you get a patient who's angry or who had a fight and they hit someone, for example. And you're asking this patient, instead of letting the patient tell you, oh, he was angry, you ask them, Wallah, you were angry, weren't you? So this is sort of a leading question. No, you don't want that. You want an open-ended question. You need the patient to tell you that they were angry. So that's avoiding leading questions. Then you have correcting the patient's thinking. Now, the example given in this slide is with medication. So let's say a patient, you're going to start them on medication. And the first thing the patient says is, what are the adverse effects of those medications? So now you need to correct their thinking. Instead of giving them an answer about the adverse effects, you need to go like, okay, so the benefits of this medication is better because of this, this, and this. You need to correct their thinking. So again, open-ended questions, avoid leading questions, correct the patient's thinking. And then 4 techniques that you need to remember. They are reflection, facilitation, confrontation, clarification, and interpretation. حلو. They might seem a lot, but let's go to the slide for it. If you look at their names, you could sort of explain or get to know what they mean. يعني صراحة. I could give you the examples right now. I had examples in mind, and you guys could tell me which one it is. But let's say a patient comes to you, and this patient tells you, Wallah, I just feel like nothing matters anymore. All right. And you, as a clinician, you respond back and you're like, okay, it sounds like you're feeling hopeless. This one is pretty difficult, صراحة. But which one do you think? Which technique is that? A reflection, facilitation, interpretation?
So I think reflection.
Yeah. So it is a reflection, because reflection is basically, as written here in the slide, you're repeating what a patient has said to you. So the patient came and he was like, I feel nothing matters anymore. You just replied, oh Allah, you feel hopeless. You're basically repeating it. Like, let's say another patient, he comes to you and he's like, I'm having troubles sleeping late. And you as a clinician, you nod and you say, go on. What's that?
You're facilitating.
I just noticed that I wrote go on here. Okay, this shouldn't have been. Okay, so yeah, this is facilitation. You're expecting the patient to tell you more. There's nothing to work with right now. Like, let's say you have this patient. He came to you and he was like, Wallah, I've been missing work a lot lately, and however, I don't think I have a problem with مثلا alcohol or drinking or anything. I only drink a few beers every night. And then you, as a doctor, you correlate it and you're like, okay, so earlier you mentioned, missing work because of drinking. That seems like it might be affecting your life or something like that. Which technique would that be?
Interpret or confront. Wait, interpret.
You're confronting the patient at this point. You're confronting them because you're pointing out something the patient is not seeing. So he said, no, he doesn't feel like the drinking is affecting them. However, it is affecting them. They're not attending. They're missing work. Like, another patient comes to you and they're like, okay, I keep getting these thoughts that won't get away. And you as a physician, you say, okay, so can you tell me more about what kind of thoughts? Yeah, clarification, exactly. That is clarification. Now, the last one is when you have interpretation, basically, and the patient comes to you and is like, okay, I keep pushing people away even though I don't want to be alone, okay? And this patient or this physician replies and he's like, okay, it sounds like you might be afraid of getting hurt, so you get distance, and so on and so forth. But they're trying to explain to the patient or say to the patient why he's doing something, right? But this is interpretation. Are all those interview techniques clear? You could get a quick question on it, a scenario on it. Are they clear? طيب. So again, coming back to our 7-point scheme, we start with introduction, and then we go on to putting patient at ease, and then history taking, the interview techniques, and the fifth thing is you need to assess for suicidal risk. It's really important to assess for suicidal risk, and we'll talk about more at the end in mood disorders, actually, how important it is when dealing with depression. But don't forget suicidal risk. And then I should have added here plus alcohol consumption as well. I remember two things, suicidal risk and alcohol consumption. The last thing, or two more things actually, are exploring emotional content and the mental state examination. So emotional content, again, I put like 6 points really quickly, and they're all common sense, by the way. So you let their thoughts flow, you make sure that you don't give any premature reassurance, you don't ask the patient why they're feeling something here or there. You're approaching their traumatic, when you approach their traumatic experiences, you need to make sure you're approaching them carefully. You're letting the patient open up to you without you forcing it out. And then you have validation and bridging. Like, bridging is important to remember, by the way. Do you guys know what bridging is? So bridging is basically you're trying to rewire, like I said, connect sort of what the patient is saying right now to a possible question you want to say. The example given in your slide is when a patient comes and they feel sad and they tell you that they feel sad that they lost someone or something. And you reply as a physician and you're like, okay, so you feel sad. A lot of people think that, or a lot of people who are sad start thinking about suicide and so on. So have you had any of those thoughts? And now you're asking about their suicidal risk as well. Now, finally, we have the mental state examination. Now, all I need you guys to remember about the mental state examination, which actually came to us in an FAQ, is it measures cognitive impairment. And why is it used? It's used for assessing the mental function and the memory of the patient. Okay, remember those words. Just when it comes to the question on an FAQ, copy paste it and put it in. It's used for measuring function and memory, mental function and memory. طيب. And this is basically done for the interview process. I'm hoping this sort of made it simple for you guys. Is it simple? خلاص? 7 points, are they good? Okay. طيب. So now onto the 4 Ps. These are again really simple. I doubt you'd get asked about this, just in case. Instead of explaining them, I have an example ready as well. I'll give you guys the example and you could tell me what are the predisposing, perpetuating, precipitating, and protective factors. So let's say you get a 30-year-old woman and she presents with anxiety, okay? She has a previous family history of anxiety disorders. And recently she went through a breakup. And also, she's facing a financial problem. And at the end of the day, she goes back to her close friend and she speaks to her. What's this? So let's start. Predisposing factors. What are the predisposing factors? We said that she was a 30-year-old woman. Maybe I should have written that one down. But okay, so she's a 30-year-old woman presenting with anxiety. The predisposing factor we said, she has a family history of anxiety disorder. That's already predisposing. That's something there. Then we also said, she's currently going through a breakup. What would that be? Is it precipitating? Is it perpetuating? Protective? Precipitating? Yes, it is precipitating. So because of the breakup, she now has more anxiety. Okay. Like we also said, she also has financial debt. Perpetuating, protective, it's perpetuating actually, because the financial debt is something that's always there. Perpetuating means that it is something always there throughout the person. Okay, and finally, the protective factor is her friend. She goes and speaks to her friend. تمام? All of this good? حلو. طيب, these are two things you need to remember to avoid doing in a psychiatric interview. Again, avoid acting as if you understand what the patient says. So you cannot tell them, oh, Allah, I know what you're going through. It's fine. تحصل, حصل خير. Of course, all of those are important, but you would never know. And then you have relationship with the patient, pretty self-explanatory. طيب. Final thing before we end this part or this lecture as well is default mode network. Do you guys know what default mode network is? Default mode network is the thoughts in a patient's mind when they're left alone or undisturbed. Okay, again, it's pretty low yield, but know it just in case. It's the thoughts when the person is left undisturbed. How you could find out what those thoughts are, you ask them, well, what are the thoughts that come to mind before you sleep or during driving or whatever action they're doing that they don't require much focus when they're just thinking. طيب. Mental state examination, we already said this. It measures cognitive impairment and it's used for mental function and memory. Please memorize. Now, this is how the mental state examination is. It's a 30-point score. They ask them a couple of questions and they assess the mental function. Right. And we're done. We're done with this lecture as well. Is it good? خلاص. Could we move on? Here's a question. A 59-year-old man comes to the physician because of unexplained weight loss over the past 8 months. During the examination, he tells the physician that he has been having marital issues with his wife. He filed for bankruptcy 2 months ago for a business he had owned with his brother until his brother died of skin cancer a year ago. He has tried to hide his financial issues from his wife and explains that he is feeling increasingly desperate and no longer sees the light at the end of the tunnel. He worries about finances and what would happen if he developed cancer like his brother, and then cannot fall asleep. In the morning, he feels tired and finds it hard to start the day. The patient says the symptom began a few months after his brother's death, and then everything started to fall apart. I can't concentrate, my wife will probably leave me soon, and now I have lost the business. Which of the following is the most appropriate reaction by the physician? طبعا, I won't lie, this case is very long, and you probably will never get asked a question like this in the exam across all the 15 lectures or 14 lectures. But I wanted to test something. What do you think the answer is? Okay, there's an A. Any other answers? All others seem illogical. Okay, so A. What's the technique used here? What's it called? Bridging, exactly. That's perfect. Now we're done with the boring lectures. And again, I'm telling you, the questions are going to be very simple on them, inshallah. And you don't have to worry much about them. Now, let's take a look at anxiety disorders. And if you guys need a break, you could let me know. Yeah. I was thinking maybe you could take the break after anxiety disorders, but yeah, up to you guys. Now, for anxiety disorders, we need to know something. What happens is that your frontal lobe is no longer working. Why? For some reason, your frontal lobe stops working and it affects, and what did we say the importance of the frontal lobe is? It's to control your limbic system. So if your frontal lobe is no longer controlling your limbic system becomes hyperactive and it starts firing a lot. What does this do? It causes anxiety. Okay, there are two types of anxiety, realistic and neurotic anxiety. Realistic anxiety is an actual reason for a person to be anxious. So let's say I'm anxious because of losing someone, مثلا. This is realistic anxiety. I have an exam tomorrow. I'm anxious about it. But this is realistic, it makes sense. But neurotic anxiety, this person, they just want to get anxious. It's a problem inside their brain. طيب, how would anxiety patients present? Would they come to the doctor and tell you, well, doctor, I'm very stressed? Is this like the typical presentation? What's their typical presentation? They come to the doctor because of unexplained medical symptoms, specifically GI or headaches. So they'd have GI symptoms or headaches, such as they could have vomiting, nausea, diarrhea, whatever, but they have GI symptoms. And this is because of their anxiety. But they won't come because of stress. Now, for this lecture, the doctor spoke about 5 anxiety disorders. I forgot to add a box for another one. General anxiety disorders, social anxiety, panic, and agoraphobia. So let's start with general anxiety disorder. What is general anxiety disorder? There's excessive anxiety. صح? For how long? Yes, so more than 6 months. If it's less than 6 months, you're thinking more of, you could say adjustment disorder. And then you have the demographics. Males are twice as more to get anxious than females. Oh, max. So females are twice as more than males. And why do you think, what are the reasons females could have more or are more prone to general anxiety disorder? There are 4 reasons actually. One, there's a complex amygdala. Okay, so yeah, limbic system is more. So a complex amygdala. Then they're more prone to poverty, they're more prone to physical and sexual abuse, and finally, their hormones. Fluctuation of the hormones leads to a more complex or female patients more prone to have general anxiety disorders. Right. So what happens in general anxiety disorders? We said we have the amygdala hyperactive. The hyperactive amygdala will cause what? It would stimulate a region in the brain called the locus ceruleus. And this region will start releasing a lot of norepinephrine. And this norepinephrine is going to cause all the problems. But is this pathway bad all the time? Is this not good for you? No. Norepinephrine is actually really important in the brain because it acts on, yes, it depends. Because it acts on what? Do you know what does it act on? The dorsolateral prefrontal cortex. So where your working memory is. So when you have norepinephrine, you have the dorsolateral prefrontal cortex, it starts working better. However, when you have too much norepinephrine, that's when your dorsolateral prefrontal cortex no longer handles it and it shuts down. And this is where your anxiety starts happening. Okay, this diagram is just to depict how norepinephrine works. So as you can see, at the beginning, up to here, it's very good. And then here you're at the flow or your best. And then if it gets more, then you start dropping down. You're stressing, and this is anxiety. طيب. Now, regarding the symptoms of anxiety, they are really simple if you think about. You could divide them into 2 sections, acute and chronic. But if you're general anxiety disorder, you're thinking more of the chronic symptoms. Acute symptoms would be anything sympathetic. If you have too much norepinephrine, you'd have high heartbeat, heart rates, increasing blood pressure, people dilate, sweating, tremors, trembling. All of those signs are acute. Now, chronic. What are the signs of chronic? Remember, you could have muscle tension, irritability. Anxiety disorder patients always have difficulty sleeping, and decreased energy, restlessness, all because of their sleeping. So yeah, those are all symptoms you probably might, I think, actually, yeah, you could get asked about. I remember I passed about it. So you could get asked about the chronic symptoms. So I try to keep them in mind, yeah. طيب. Now let's differentiate between anxiety and depression. So let's say I get a patient, and this patient tells me, oh, wallah, I'm having difficulty falling asleep. Is that anxiety or depression? Anxiety. And if they say, مثلا, okay, I'm waking up in the middle of the night, this is depression. Perfect. طيب. Another thing to differentiate is between anxiety and worry. Anxiety is continuous, while worry is temporary. I worry about something happening soon. I worry about it for a temporary period of time, while anxiety is very continuous. طيب. Now, risk factors for general anxiety disorders. typical risk factors if you think of any disease. If you have any disease, you need to think about their lifestyle, you need to think about their social influences, their family history, anything that causes that. But one really important thing to remember about general anxiety disorders is, you guys know, a risk factor. Stress, that's part of the family background, social life. GABA. Need to think about GABA. So some people have less GABA, and less GABA means more excitation, and this would eventually lead to anxiety. But remember GABA. Like, what are the other hormones involved in general anxiety disorders? We already said high norepinephrine. What else? Cortisol. And we already spoke about some of the comorbidities of norepinephrine. So if we have high norepinephrine, we said we could have hypertension. Other conditions could be like, yes, cortisol releasing factor, yeah. Cortisol, generally cortisol. You could have hypertension, you could have myocardial infarction, sudden death, and then cortisone could lead to diabetes mellitus. Like, now let's take a look at the DSM-5s for anxiety. We already said it's excessive worry for more than 6 months. Those people would be unable to control their worry. This is the second criteria. And finally, they have 3 or more of the chronic symptoms. Okay. Now, signs to notice about general anxiety disorders are fidgeting, teeth grinding, heart race, feeling tense, no sex drive, rocking, fetal position. Now, which one of those is not for anxiety? Five, no, it is part of anxiety. All of those are common signs. 1, 7, yes. So fetal position. Fetal position is not a sign of anxiety, it's a sign of depression. Okay, that's all the first 6, they're all signs of anxiety. Okay, try to notice them in the questions because it could indicate anxiety. If you see 7, it's not anxiety, it's depression. Right, now let's take a look at social anxiety disorder. But before we move, let's ask a couple of questions. What's social anxiety disorder? They have excess anxiety of what exactly? Social situations, and yes, perfect, public speaking, because this is like the key word in all the questions regarding social anxiety disorder. If you see a fear of public speaking, your mind should go to social anxiety disorder. How long? How long should they have this fear to be characterized as social anxiety disorder patients? 3 months, weeks, or days? Yeah, none of them. 6 months. It should be greater than 6 months. Type, who are more prone to have social anxiety disorders, males or females? Females. And what's something that you could see in childhood and you could be like, okay, so this patient or this kid is probably going to grow up and have social anxiety disorder. What's, nope, not abuse. Mother, يعني you're around the point, shyness. This patient, isolation, yeah, but shyness, a shy child, because children should be very active during their childhood. So if a child is shy and isolated, like you said, all of those would indicate that, oh Allah, he's more towards social anxiety disorder. But now, what's the most common or the main fear of a patient with social anxiety disorder? Remember this one. This one is important. Their main fear is not fitting. Nope. Nope. Public speaking. Their main fear would be negative evaluation, unable to satisfy others. Yani negative evaluation by others. Okay. So their main fear is negative evaluation by others. They usually come to the doctor because of depression or something else. Now, in childhood, they could have one of 2 scenarios, one regarding the mom and one regarding the dad. So it could be a cold or sad mom or a critical dad. Okay. If there's a cold or sad mom, then the child is probably going to grow up and have social anxiety. Or if it's a critical dad, like if it's a dad who's always saying satisfying or motivating stuff to his child, the child will grow up and have social anxiety. Fine. Those are 2 things. SubhanAllah, it happens. Okay, so this is for social anxiety disorder. Treatment, medications, and CBT. This is basically for all anxiety disorders. We're going to talk about them at the end, inshallah. But now, is social anxiety disorder good? See, okay. Let's take a look at panic disorders. What are panic disorders? The patient would have generalized fear. Okay, it could be gas like that. The panic disorder patients, they'd have suddenly a recurrent and it could be recurrent as well, high levels of norepinephrine in the body because of a certain trigger that happened. And they also have a common thing. Their fear is, the most common fear is the fear of what? Having another panic attack. For those patients, yeah, their most common fear is having a fear of another panic attack. And they present, as we said, with high norepinephrine. That they have high norepinephrine, for those patients who present with like shortness of breath, they be trembling, sweating, high blood pressure, hypertension, tachycardia, all of those. Like, if a patient comes with all those signs, what's the first thing to rule out? Cardiac, yes, اللي هو heart attack. You need to rule out a cardiac as the first thing. طيب, what's another condition that's very closely correlated with panic disorders? Agoraphobia. So those patients usually have agoraphobia. طيب, what's agoraphobia? Fear of being in what? In the crowd, in situations, like it's defined as fear of being in situations that are difficult to escape from. So that's agoraphobia. So people who, they have fear of marketplaces, they have fear of transportations, all of those. طيب. Now, our final disorder is a specific phobia. So what's a specific phobia? Having fear of something specific, like having fear of snakes, having fear of heights, having fear of one of the doctors, whatever this or that. طيب. Treatment of anxiety disorders. How would we treat? We said medications and CBT. What are the medications we should give? And then what order? SSRIs, okay. Is it only SSRIs? You'd give, yes, you'd start the patient on benzodiazepines first. You'd start the patient on both, actually. You start patient both on benzodiazepines and SSRIs. So why? Why do you do that? Because SSRIs are slowly acting, okay? And so they take time to start working. They take a period of 2 weeks. For the first 2 weeks, you need a rapidly acting drug, which is benzodiazepine. So you start the patient on benzodiazepines for more than 2 weeks until SSRIs start working. Now, why do you stop benzodiazepine? It's because it could cause addiction, okay? Like, and then you have CBTs. Is that good? This is done for anxiety disorder lecture, inshallah. Is everything clear? Everything simple? Okay, now for, am I going too fast? Okay, alhamdulillah. Now let's take a look at some of the questions, inshallah. طيب, the sister reports that, oh, I think I got this from the middle bits. Okay, that he always been a shy homeboy who is comfortable in the immediate. Okay, so he's a shy homeboy who is comfortable in the immediate family but avoids most public events. Nice. Okay, yeah, so yeah, you're correct actually. He says he wants to go out more, but feels that people will see him as stupid and boring. He attends high school, but apart from a small group of friends, he largely keeps to himself. He rarely raises his hands in class. During the interview, he appears afraid. He speaks in a barely audible voice and keeps his eyes fixed on the ground. He reports that he does not currently have chest or abdominal discomfort, and he does not appear short of breath. His physical examination is unremarkable, and his vital signs are normal. So yeah, like you said, because of the keyword shy, you could find it, and then he avoids most public events. This is another clue here and there. Your answer is most likely going to be B, social anxiety disorder. Right, next question. Now, this one is a complete question. A 22-year-old man is brought to the emergency department by his sister because of shortness of breath, chest tightness, palpitations, and sweaty hands for the past 30 minutes. His symptoms, okay, yeah, started when he was walking in the park with his um, his symptoms started when he was walking in the park with his sister. Over the past year, he has had several episodes with similar symptoms when using public transport and in crowded places. Since then, he avoids leaving his home, and when he does, he says he feels safer when accompanied by his sister. He used to attend a marketing course at the local university, but now struggles to attend classes because as soon as he enters the university, he starts to experience chest tightness, sweaty hands, and a feeling of impending doom. His mother has a history of pulmonary embolism. He does not smoke and drinks 2 beers daily. He takes no medications. Which of the following is most likely diagnosis? صراحة, are you sure the answer is E? Any other answers? طيب, which one is it more likely, A or E? Was there any trigger that caused that? Or did it suddenly happen because of, it was said, he was walking in a park. But when he was walking in a park is a crowded area or a public space. Those patients are more likely going to be agoraphobias, okay? Not panic disorders. Cool. طيب. A 22-year-old college student reports having several unpredictable episodes of intense fear, accompanied by dyspnea, diaphoresis, palpitations, chest pain, and tremor. The episodes, which have occurred a few times a week for the past 2 months, begin abruptly and reach a peak within 10 minutes. They occur unpredictably and can happen anywhere when they occur in public areas, such as in class or while the patient is driving. If he's uncomfortable and imbalanced. Yes, okay, so this one is more towards panic disorder. Perfect, B. Now, final question. A 36-year-old woman comes to the physician because of an 8-month history of an occasional tremor. The tremor is accompanied by sudden restlessness and nausea, which disrupts her daily work as a professional violinist. The symptoms worsen shortly before upcoming concerts, but also appear when she goes for a walk in the city. She is concerned that she might have neurological illness and have to give up her career. The patient experiences difficulty falling asleep because she cannot stop worrying that a burglar might break into her house, her appetite. Yeah, so yeah, it's leading towards general anxiety disorder because she has fear of almost everything. Right? And that's it for this lecture as well. Now we have 2 more lectures left, or like 3 technically, mood disordered 1 and 2, and schizophrenia. Would you guys like a break? And sure, let's 5-minute break. We could come back at 10:53. Okay, so let's get back into it. Mood disorders. So this lecture is all about depression and its related disorders. Okay, so let's begin. Major depression. So what is major depression? Depression that is basically the feeling of depression, and then it comes back to a normal interval over here. And then it depresses and comes back to a normal interval. Right. So stuff to remember for the exam. First, female to male ratio is 2 to 1. Yes. So the two main things to remember, anxiety and depression, both have female to male ratios of 2 to 1. Like another percentage you could try remembering is that 20% of the population are affected by depression. Treatment is CBT and medication, and we're going to speak about the electroconvulsive therapy as well later on. Like, let's say a patient comes to you and they have depression after this, their age is like 60 plus. What are you thinking of? So you got, okay, a patient whose age is 60 plus, and they come suffering from depression. What diagnosis are you thinking of? What condition? Alzheimer's? Yeah, around this اللي هو dementia. You're thinking of dementia. طيب. For major dementia, for major depression, you need to ask or check for two main things. It's very important before diagnosing major depression. You need to check for two things. What are they? Childhood. You need to assess for suicidal risk. We spoke about in, yes, suicidal risk. We spoke about in the psychiatric interview lecture, and for mania. Why is it important to check for mania? For bipolar, بالظبط. Because this patient, if they're bipolar and you give them antidepressants, it's going to stimulate their mania, and it's going to cause a lot of problems. So I need to check for suicidal risk and mania. طيب, for suicide patients, what's the typical suicidal patient? Like there's a typical demographic of a suicidal patient. They present lost hope of life. They do, yeah, they are. They're depressed. But they're usually a 50-year-old single male. Okay, if I remember this, a 50-year-old single male is the most common typical suicidal patient. Tamam? Midlife crisis. Yeah. Okay, so now, for medication. When do we start medications for depression? Do you start them right away? Like a patient comes in, it's their first episode of depression, you give them SSRIs or antidepressants? No, when? Third episode. After their third episode of depression, they come to you, you start them on medications. طيب, what are the regions in the brain that are affected by depression? So in anxiety disorders, we said you have hyperactive amygdala because the frontal lobe is no longer working. But in the depression, okay, so frontal lobe is correct, hippocampus is correct. What else? Dorsolateral prefrontal cortex, which is the frontal lobe. The amygdala is affected. So the frontal lobe, both the dorsolateral prefrontal cortex and the orbitofrontal cortex are affected. We also have the hippocampus, so they'd have their memory could get affected. If it's severe depression, they could have loss of memory. And the amygdala is affected. Again, severe depression would cause irritability in mood. But this is the stuff. The main thing you need to remember is that the dorsolateral prefrontal cortex is affected. طيب. So those patients, it's said that they have hypofrontality because both their frontal lobes are down. طيب. But how could you treat them? There's this treatment which we call, you guys know the treatment, possible treatment for it because of the frontal lobe. It's called transcranial magnetic stimulation. Transcranial magnetic stimulation, which stimulates your frontal lobe, and so it gives it activates the neurons, basically. Yeah. Right. So those are for the regions that are affected by depression. Now the neurotransmitters. Try to always have this order in mind. You get a condition, you assess the regions affected, you assess the neurotransmitters. GABA, no. GABA what's for? Anxiety disorder. So norepinephrine, yes. The dopamine, yes. And one very important one, your happy hormone, serotonin. Perfect. But serotonin is the main one. And then you have dopamine. If they have low dopamine, what do they have? Like, what will they suffer from? Procrastination, no motivation. Perfect, yeah. And for norepinephrine, what would happen? If you remember the diagram we showed, no. One side it was stressed, on this side, yes, energy less, low energy. طيب. So now, okay, you get this you get these two patients, and okay, so which one has depression, left or right? Left. Okay, this one or two? Hypofrontalis on the left. Yeah, exactly. This guy, the frontal lobe is no longer working. حلو. Like we also said, so this is hypofrontal. We also said about the hippocampus. So you could see here from this diagram, the longer the episode of depression, the hippocampus gets affected and it starts going down. And at the end of the day, what will happen? What will happen? Loss of memory. حلو. Now, final thing before we get into the DSM-5s for major depression is the difference between males and females when it comes to depression. What do males do when they're depressed? And what do females do when they're depressed? Tend to abuse drugs. Okay, so males, abuse drugs, they go gamble, females would cry. Yeah, so males would gamble, they would be aggressive, they would abuse drugs, and females would self-destruct. They wouldn't per se cry, but they would do self-destruction. They would lower their self-esteem, and they would have low self-esteem, and they would be chronically procrastinating. What are self-destruction? They could start trying to look ugly to the world because of depression. They don't want anyone else. Okay, so this is male versus female. So female is inward, male is outward. Right. Now for DSM-5s for depression, we have a mnemonic for it, which is called depressed SIGECAPS, whatever you want to call it. Depressed mood. F for sleep disturbances. We said they have multiple awakenings in the night. I is for interest loss. G for guilt. E for energy loss. C for concentration. A for appetite changes. P for psychomotor agitation. And S for suicidal ideation. طيب, the two reds, I need you guys to remember, you need to have one of them. And everything else, you need to have 4. And that's major depressive disorder. حلو. All good? Perfect. Now, depression, let's take a look at depression and how it affects sleep. So we already said, you have middle night awakenings. There are two other things that happen with depression. So middle night awakening is one, and then there is no deep sleep. Perfect. So those patients are irritable. Final thing is short-term latency. So 3 things happen in depression: short-term latency, no deep sleep, and middle night awakenings. حلو. طيب. So we also said, if you have depression is more than 6 months. If it's less than 6 months, we said it's gonna be like anxiety, by the way. We said that anxiety is more than 6 months. If it's less than 6 months, we said it's going to be adjustment disorder. Perfect. But less than 6 months is adjustment disorder. If you really want to know what adjustment disorder is, it could be anxiety, it could be depression. It's a maladaptive emotional change that happens, and it lasts for less than 6 months. This is adjustment disorder. But let's say a patient who is depressed, they sleep too much or they eat too much. What do they have? That's atypical depression. No, that's atypical depression. Because usually when a patient is depressed, we said they have problems in sleeping, they have middle night awakening, so on and so forth. But this patient is sleeping too much. And the other person, they have lots of interests. They wouldn't want to eat. They wouldn't want to take care of themselves. They wouldn't want anything. But this, and here you have increased appetite. Should be less appetite. Atypical depression is the opposite. But how would you treat atypical depression? What's a common treatment for it? monoamine oxidase inhibitors. Perfect. So let's say you have a patient who has depression, but it's minor, and it lasts for more than 2 years. That's this dysthymia. Okay. So if it's minor depression, it's not that severe, and lasts for more than 2 years, that's called dysthymia. But what if it's very severe depression? Very severe. And it causes something, a key word for it is psychomotor depression. Very severe depression. It could cause begin with the C. No, صراحة ends with the C though. It's called melancholic depression. That's very severe depression. And the patients have psychomotor depression. What's psychomotor depression? That's slowed movements. That's they have slowed speech. They have a weak thought process. It's very severe to them. They could have memory, loss of memory, because it's very severe depression. Remember, psychomotor depression, melancholic depression / severe depression together. طيب. Let's say you have a patient who has depression, and then there's hallucinations and delirium and all of those. What's that? Depression with psychotic features. We call it depression with psychotic features, when there's delusions, when there's hallucinations. And how would you treat this one is through APS. You treat it through electroconvulsive therapy. Okay, so let's review the treatments really quickly. Right. For hypofrontality, we said we could use what? Transcranial magnetic pulse. طيب. For what was it? The atypical depression. What would you use for it? Monoamine oxidase inhibitors. And for depression with psychotic features, you'd use electroconvulsive therapy. تمام? Remember those things. But let's say you have a patient, a woman, and she gave birth, and within the first 4 weeks, she had depression. Postpartum. It's called peripartum onset peripartum depression. Okay, so this depression happens within pregnancy or the first 4 weeks after childbirth. That's peripartum onset peripartum. But let's say she gave birth, and within the first 12 months, she had depression, loss of interest, all the SIGECAPS, depressed SIGECAPS. What's that called? That one is postpartum. Yeah, that one is postpartum depression. But what if it's the same lady, but she didn't have as severe symptoms? That's postpartum blues. ممتاز. Now let's say this patient, he comes and he has depression every single year from the months of August till March, let's say. Seasonal affective disorder. ممتاز. And why does it happen? Because of low sunlight. And why is sunlight important? For serotonin, tryptophan, serotonin. طيب, how would you treat them? Light therapy. ممتاز. One final thing is Freud's depression. What did Sigmund Freud say about depression? What is his ideology on depression? What is depression to Freud? He said, remember this, it's Freud's depression is, yes, anger or depression turned inward. The example in this slide, I don't know if you could say it or not. Yeah, okay, let's say. So you had this lady, and she wanted to marry someone, and her parents did not agree of it. تمام? And this lady started getting depressed and angry. حلو. And what happened after? She started getting not caring for herself. So this is his explanation. No, it's depression turned inward. Like pointless example صراحة. Now for treatment of depression, We said CBT, SSRIs, and electroconvulsive therapy. We added some monoamine oxidase inhibitors for atypical depression, or we said transcranial magnetic resonance for hypofrontality. All of those are good. Tamam? All good? طيب. Now let's take a look at bipolar disorders. What's bipolar? Bipolar is having depression and then a period of mania, and then a period of depression and then a mania. But is it fully mania or depression? You cannot really tell, because it's like the doctor said, a roller coaster of emotion all over the place. You cannot predict their moods. We could have mood swings. طيب, what's the best advice you could give to a patient who is bipolar? Not to him, but to his family. Control money? Yes. So you do not let them be in control of their money. Why? Because when those patients have a mania episode, they have rash decisions, they are irrational, impulsive, and very important to remember, and it's a clue in the questions, excessive or reckless overspending. Remember it. Excessive or reckless overspending is towards bipolar disorder. طيب, what's a very high risk factor for bipolar disorder patients? Sleeping. Blood relatives, having a blood relative. Usually a first degree blood relative is a very high risk for bipolar disorders. And it could get transmitted, but it needs a trigger. What triggers it? Like you said, the stress. So when you have stress, and then you already have a history of bipolar disorder, when this stress and bipolar meet together, خلاص. طيب. Here are some signs of bipolar disorders. They could have, in the question, could tell you, well, this patient has many jobs, a lot of failed relationships, and very important to remember, excessive unnecessary spending. Hey. How would they present? Again, this is directly from your slide. Remember the mnemonic, I dig fast. What does I stand for? Irritability or indiscretion. Okay, and then D for distractibility. They're easily distractible. Another I for insomnia. G, grandiosity, light of ideas, activities. S for speech and sleep, and T for thoughtlessness. حلو. Types of bipolar disorder, we have two types, bipolar 1 and bipolar 2. Let's take a look at bipolar 1. What happens in bipolar 1? How many weeks of mania? How many weeks of depression? Okay, 1 week of mania and how many weeks of depression? 2 weeks of depression. Perfect. Do they have hallucinations? Oh, no? Are you sure? Bipolar 1. Yes, bipolar 1 has hallucinations. Do they have history of hospitalizations? Yes, they do. Bipolar 2, as you can see, it's 4 days of hypomania. Remember, differentiate between mania and hypomania. The bipolar 2 is less severe than bipolar 1. And it's followed by a period of depression. Does it have psychosis or hallucinations? No, and there is no hospitalizations either. Perfect. Now, for cycling of bipolar, when do we call it rapidly cycling, and when do we call it like normal cycling bipolar, or slowly cycling? Okay, so perfect. More than 4 is rapidly cycling, and if it's slowly cycling, it is usually 2 to 3 episodes a year. Perfect, ممتاز. More than 4 is rapidly type. And basically, this is all you need to know about bipolar disorder. All good? Yes, alhamdulillah. Now, for cyclothymia, what was cyclothymia? We said, when I spoke about minor depression, you said cyclothymia. But minor depression is dyspnea. What is cyclothymia? You'd have minor depression plus what? Hypomania. Look at this diagram over here. But you can see مثلا dyspnea, you only have minor depression, okay? This is dyspnea. And then for cyclothymia, you have minor depression and hypomania. Minor depression and hypomania. Like for bipolar 1 and bipolar 2, you can see here bipolar 1, you have mania and depression, and there's a possibility of psychosis. While bipolar 2, it's only depression and hypomania. Okay, schizoaffective disorders and the rest we're going to speak about in different lectures. Here, major depressive disorders we already spoke about, and here major depressive with psychosis. Tamam? Is this diagram clear for everyone? So cyclothymia is you have depression, minor depression, and minor or hypomania. Type, how long should the patient be so that you could diagnose him with cyclothymia? He has depression and hypomania. Like from the first 2 weeks, you could diagnose it. How long should he stay like that? 2 months? Yeah, خليها بقى 2 years. From 2 months, 2 years. It's 2 years. If they have more than 2 years of hypomania and minor depression, then that's cyclothymia. ممتاز. طيب, let's take this case. You have an asthma patient. They were started on cortisone inhaler, and 2 weeks later, he started becoming hypermania. Could you say, no, this guy has mania because of bipolarity? No. What is it, طيب? Substance-induced mania. So this is substance-induced mania. So again, you need to remember to rule out any drugs or alcohol used by those patients to diagnose them with bipolar or depression or anxiety. Right. What is the most common comorbidity with bipolar disorder patients? They would come and they would say, no, Allah, they're suffering from severe headaches or migraines. Remember, migraines. Perfect, migraines. Right. What region of the brain is affected by bipolar disorders? Orbitofrontal cortex. Now, I thought the answer would be dorsolateral prefrontal cortex, but yeah, it was orbitofrontal cortex. Very correct. Now, neurotransmitters. What are the neurotransmitters in bipolar disorder? Serotonin. Any other neurotransmitters that could come to mind? GABA. Okay, that's okay. So you have GABA and glutamate. Perfect. GABA and glutamate. So the imbalance between those two could cause bipolar disorder. Like, how would you manage a patient with bipolar disorder? So a patient comes in and you know his history. You know, Allah, he has multiple jobs, multiple relationships, multiple or excessive spending, all of those. خلاص, he comes and you diagnose him with bipolar. You say he has bipolar. NMDA antagonist. Okay, that's for the treatment. Okay, that's for the treatment. But would you give them the treatment without diagnosing them first? How would you diagnose them? Remember the Young Mania rating scale. It's very important to remember. Young Mania rating scale. You cannot start them on lithium right away. You need to do this scale, and you do not really need to know the questions because I doubt you get asked about. But remember, in the Young Mania rating scale is important for diagnosing bipolar disorder patient. And like you said, what's the gold standard treatment for it? Lithium. Yeah. So why is it important? Because it lowers their suicidal risk. What are the side effects of lithium? It causes them to feel very sedated and like a zombie feeling. They don't like getting out of bed and they're bored. So because of that, there's another thing you need to make sure of when giving them lithium is they cannot handle their own medications. Why? Because those patients, bipolar disorder patients, like we said, they have grandiosity as well. If you remember, I dig fast. So they like feeling that way. They like feeling important to people. This is why you cannot let them handle or be in charge of lithium. تمام? It is a research question, صراحة. But yeah, for gold standard, طبعا they don't usually use, by the way, lithium. They use other drugs, but gold standard treatment would be lithium. If you get asked about a gold standard treatment, it would be lithium. Right. So as we said, for bipolar disorder patients, you do not let them be in charge of their medications because they like the high, they like feeling grandiosity, and they like being big. Right. This is done for bipolar disorders. Are there any questions? Is everything good? Okay. Now for my long questions. Okay, so a 34-year-old man comes to the physician with a 2-month history of difficulty concentrating at work. He's worried he may lose his job due to poor performance. He feels constantly tired, but attributes his fatigue to waking up early most mornings and being unable to fall back asleep. His wife has noticed that he has been speaking more slowly than usual and his appetite has decreased. He used to enjoy dance classes with her, but has not been as interested in this recently. He's a veteran who returned from a deployment to Afghanistan 2 years ago. Which of the following is the most likely diagnosis? Answers. Okay, so we have an A, major depressive disorder. Anything else? Okay, correct. Major depressive disorder. Persistent depressive disorder we didn't take. And then you have adjustment disorders. He said here, it's more than 2-month history of difficulty is what it may. Oh, if it's a 2-month history, you're more thinking about, by the way, adjustment disorder. Because if it's not 6 months, this is the criteria that if it's more than 6 months, then it is major depressive disorder. If it's less than 6 months, you're thinking about adjustment disorder. I'll check this question and come back to you. Right. Next question. Psychomotor depression is a symptom of which of the following? You said about this? B, severe depression, or its other name is melancholic depression. Perfect. Right. A pouting and demanding 25-year-old woman begins psychotherapy, stating that she is both desperate and bored. She recounts a 5-year-old history of short episodic bursts of anxiety and depression, several theatrical suicidal gestures, and impulsive and self-defeating behavior. She has abruptly terminated 2 previous attempts at psychotherapy. Her mental status examination showed her reality testing to be intact. What would be the next step? C. So yeah, you need to make sure or assess the risk for suicide and safety plan. Perfect. طيب, Afaf is a 30-year-old female who started having mild symptoms of depression with low energy, episodes of crying and caring for the baby. These symptoms began in the first month after her baby was born. It did not interfere with her daily activities. Did you say B? Yep. Perfect. So yeah, it is B because it does not interfere with her daily activities. But Amani is a 30-year-old woman who reports feeling anxious with a hard time staying asleep. She also reports symptoms of losing interest in doing things, feeling guilty and unmotivated with low self-esteem, and some death wishes. Her symptoms worsened after the birth of her 2-year-old boy. The most likely diagnosis is B. Any other answers? So this question is a trick question, actually. The answer here is A. Yeah. Why? Because it's after the birth of her 2-year-old, but it's been more than 12 months. We said in postpartum depression, postpartum blues, they happen within the first 12 months. If it exceeds 12 months, then you're thinking more about major depressive disorder. Make sense? Last night, the media broadcasted a 55-year-old man who committed suicide by gunshot. He most likely has a history of E. So if I remember, we said, a typical presentation of 50 midlife crisis, 50-year-old plus. Top. A 20-year-old university patient presents with symptoms which lasted for 2 months and got worse in the last 2 weeks. She started many projects but does not finish them and gets distracted easily, which has affected her grades. She sleeps less but doesn't feel tired. She's impulsively buying unnecessary things. Her friends say she's unpredictable and gets too excited or too angry over little things. What is the management for her? Perfect. Young mania rating scale to rule out bipolar. Even though it's a very characteristic or typical case of bipolar, you still need to do the young mania rating scale. حلو. طيب, a 47-year-old woman has not been feeling like herself for the past 6 to 8 months, and is unable to enjoy anything. She feels sad and anxious. She had difficulty sleeping and is always tired. She has decreased appetite and lost 10 kgs in 6 months. Perfect. Again, more detailed history to rule out bipolar. Why? Because you can't start her on antidepressants, because if you do, she could go mania. Like a 27-year-old woman has been feeling the blues for the past 2 weeks. She has little energy and has trouble concentrating. She states that 6 weeks ago she had been feeling very good with lots of energy and no need for sleep. She says that this pattern has been occurring for at least the past 3 years, though the episodes have never been so severe that she couldn't work. Which of the following is most likely? Like you said, cyclothymic disorder. And we said, what was the cutoff point for it? How many years? 2 years. For more than 2 years, and it's stated in this question, it's been 3 years. ممتاز. Okay. Final question. Samira is a 28-year-old female who was referred to a psychiatrist by her primary care physician for inadequate response to treatment of depression. She is overweight with mood swings accompanied by paranoia. ممتاز. Yeah, bipolar 1 disorder. She has excessive money spending and irritable mood, which usually lasts for 2 weeks, followed by 1 month of depressive symptoms. Which one of the following is the most likely diagnosis? Bipolar. حلو. Okay, we're done with this lecture, mood disorders, and onto the final lecture. Is everything good till now? Clear. Now for schizophrenia. Schizophrenia is what's called the انفصام الشخصية, or when you have your characteristic or personality is divided into 2. And it's characterized by a couple of symptoms, but we characterize them into 3 sections, or divide them into 3 sections. Positive, negative, and cognitive symptoms. How I like to think of it, positive symptoms from its name, you add something to the patient. What are some of the positive symptoms you could think of? Hallucinations, delusions, disorganized speeches and talk. And try to remember those symptoms, by the way, because you could get easily asked them. So negative symptoms, what about them? Withdrawal from society, anhedonia. They could have like a blunted face. They could have loss energy and low motivation. Type cognitive symptoms. They'd have memory issues. They would be unable to focus, process social cues. They have impaired sensory perception. All of those are cognitive symptoms. Type. For negative symptoms, try to remember something. Lower thought blocking is an example of a negative symptom. Right. Let's take a look at the symptoms related with the different phases of schizophrenia. Okay, I wrote schizophrenia wrong here. Anyway, you have 3 phases. Prodromal, which is before the first episode of psychosis. Then you have the first episode of psychosis, and then you have chronic of long-term. But let's take a look at each of the symptoms. For chronic symptoms, are they found in prodromal stage? Cognitive symptoms are actually prominent in prodromal stage. They are very prominent in the prodromal stage. Like negative symptoms, are they present? No, yeah, بس لا صراحة they are. Negative symptoms are also common in the prodromal. Cognitive are most prominent. Negative are common. What about positive? No? No, yes. No? Yeah. Positive are rare. Positive are not found. Prodromal is mainly cognitive, then negative, then positive. Type. Acute phase. Positive symptoms. Okay, cognitive first. Cognitive, are they prominent? Cognitive are, yeah, they are present in this stage. Negative, are they prominent? They're not. They are found, but they are overshadowed by the positive symptoms. So in the second phase, you have positive, then cognitive, then negative symptoms. Here you had cognitive, then negative, then positive symptoms. And here, chronic phase, would you have cognitive? Yes, you have cognitive. You always have cognitive. But remember, cognitive is found in all three phases. Negative symptoms are the most dominant in this phase, and positive symptoms may or may not be there. But remember, the one that's found in all three phases is cognitive symptoms. Hello? Is this one clear? Okay, so let's repeat really quickly. If I have three phases, in the prodromal phase, you have cognitive, then negative are also found, positive is not found. Cognitive and negative, CN and prodromal. In first psychotic episode, you have positive, they are very prominent. Then you have cognitive, and you barely have any negative. You cannot see them. There is some negative, but you cannot find. It's mainly positive and cognitive. Always remember, cognitive are found. You cannot escape. In chronic, you have cognitive and negative. حلو؟ فهنا cognitive, negative, positive, cognitive, negative, cognitive. Cool? It could be a little confusing يعني بس. تمام. طيب, which part of the brain is affected in a schizophrenic patient? The dorsolateral prefrontal or the orbitofrontal? Or is it neither? Dorsolateral prefrontal cortex. If you have a problem in the dorsolateral prefrontal cortex, you have no memory. طيب, you get a schizophrenic patient. What is the first thing you do to that patient? First thing, you need to First thing is you need to start the patient on medications. If you know that they are schizophrenic, you need to give them medication. Why? You need to reduce the duration under psychosis, the period of duration under psychosis. Like, let's take a look at the normal demographics. So males and females, which one is more common to have schizophrenia? Males, they're equal actually. Both of them are equal. It's as common to happen in males as in females. Like in schizophrenia, it was said, it runs in families, so it could get inherited. However, it gets inherited as an inactive gene. What activates it? So psychosocial factors or triggers. What ages are more common to have schizophrenia? At what age would it start manifesting? Adolescent, which is between which period? 15 to 24. Okay, remember 15 to 24. طيب, what are some of the triggers that could cause schizophrenia? Stress. Okay. Not a common one. Isolation. Okay. Try to remember the main four. I want you guys to remember from this. طبعا try to remember all of them. But the main four is a parental age of more than 45, use of marijuana, pregnancy or delivery complication, and urbanicity. Again, all of them are triggers, but those are commonly asked. تمام? Parental age, marijuana, pregnancy, and urbanicity. حلو? طيب, let's take a look at the pathophysiology of schizophrenia. For schizophrenia, actually no, before that, for a mother, during which trimester should we take care of her to avoid schizophrenia? Second trimester. And what also should be given during the second trimester? treat her like a queen. Okay. You need to give her the influenza vaccine during the second trimester. تمام؟ طيب. Now we could go to the pathophysiology. So the pathophysiology of schizophrenia, we could divide it into three parts. One, you have mass destruction of the neuronal cells in the brain. What would that lead to? You'd have ventricles enlarging and a decreased gray matter on imaging. تمام? This is point number one. Death of neuronal cells in the brain. So you'd have ventricles, as you can see here, they're very big ventricles, and the gray matter is decreased. طيب. And again, here is an image of how it changes. This is the first psychotic episode. After 3 relapses, it keeps on getting worse and worse. And this is why you need to start medications right away. Like, this is point number one in pathophysiology. Point number two, there is high dopamine. That's in which system? Yeah, I'll help out. Mesolimbic or mesocortical? Okay, it's mesolimbic actually. We have high dopamine in the mesolimbic system. Tamam? The third point, okay, so again, high dopamine in the mesolimbic system would cause what? Which symptoms? Positive, negative, cognitive? Positive symptoms, type, and they would cause hallucinations. What's the most common type of hallucinations in schizophrenic patients? Auditory hallucination. We also spoke about delusions. It could cause delusions. There are 5 types of delusions. What are they? If should we give examples? Okay, let's say let's say a wife is always suspecting her husband is cheating on her. What's that? What type of delusion? Hearing something weird. That's jealousy delusion. Okay. Let's say you have a patient who starts suspecting that everyone around them is planning on killing them or something. That's persecutory delusion. Persecutory delusion. Let's say a patient is thinking that he came here for a reason, and no, he's here to like cure cancer, save the world. What type of delusion that is? Grandiose delusion. Let's say a patient has a delusion and Allah, he's feeling pain, mental or physical pain. What is that? More physical, actually, physical pain. That's somatic delusion. And finally, let's say that a patient has this feeling in Allah, this particular famous person is in love with them. Erotomanic delusion. Erotomanic. Again, jealous delusion, grandiose, persecutory, somatic, erotomanic. Which ones are most common in schizophrenic patients? It's mainly persecutory. Typically in the question, they tell you in Allah they feel that someone is spying on them or planning to harm them or whatever it is. It could also be erotomania. It's more commonly persecutory. Right. Let's rewind a little back to the pathophysiology. We said we have mass neuronal destruction, and then we have high dopamine in the mesolimbic system, and then low dopamine in the mesocortical system. What does low dopamine cause in the mesocortical system? What symptoms? Positive, negative, cognitive? Negative and cognitive, both of them actually, because it's both negative and cognitive. حلو. For management, طبعا I won't really touch upon the pharmacology, but really quickly, you have for antipsychotics, you have 2 types, the first generation and the second generation antipsychotics. What do the first generation antipsychotics do? Okay, they do dopamine. What about dopamine? They reduce the dopamine in the mesolimbic system. So they reduce your positive symptoms. تمام? What do the second generation do? They increase the dopamine in the mesocortical and reduce the dopamine in the mesolimbic. Both, they do both. تمام? So they reduce both positive, negative, and cognitive symptoms. Even though cognitive symptoms will always some sorts of stay. تمام? طيب. Finally, let's take a look at the DSM-5 for schizophrenic patients. They have remember positive symptoms. You need to think a lot about the positive symptoms. So they would have delusions, hallucinations, disorganized speech. All those are positive symptoms. Then you have grossly disorganized or catatonic behavior. The people are weird. And finally, negative symptoms. حلو. طيب, how many of those and for how long? Two out of all of those for 1 month, at least 1 month. تمام? طيب, let's say it's less than 1 month. What do we call it? If it's less than 1 month, it's called brief psychiatric episode. تمام? If it's 1 to 6 months, what's it called? Schizophreniform disorder. And if it's more than 6 months, it's schizophrenia. تمام? Less than 1 month is brief psychiatric episode. 1 to 6 is schizophreniform. More than 6, schizophrenia. طيب. Finally, on to prognosis. There's this mnemonic for a good prognosis of schizophrenia. Remember, fresh, risk. F for female gender. R, okay, forget this part. Female gender, rapid onset of symptoms. So if it's sudden development of positive, negative, and cognitive symptoms, this is a good prognosis. E for early treatment, as we said, we need to treat it early as possible. Sudden onset, this is a repetition. H, higher age onset. We said the normal age is between what to what? 15 to 24. For higher age of onset, this means better prognosis. And finally, risk, which means no risk factor. Parental age was normal. They don't do marijuana. Pregnancy was 0 complications and no urbanicity. Health, is this part good? This is all done. We're done with schizophrenia. طيب, now let's take a look at what is schizoaffective disorder. Schizoaffective disorder is psychosis plus depression plus mania. So it has all signs of depression, psychosis, and mania. تمام? But remember we said major depressive disorder with psychotic features. Here it is. It drops and there is psychosis. Light blue color is psychosis. But if it's schizoaffective, you can see they have mania, they have depression, and they have psychosis. That's all 3 together. تمام? It's schizoaffective clear كمان. طيب, let's say we have a patient whose age is more than 50 years old, and this patient comes and they have like non-bizarre delusions. Like they have delusions in their mind. What's this? Alzheimer. That's more of dementia. Here they have delusions, which is a delusional disorder. So this is the typical presentation of a delusional disorder. Those patients are normal, and those patients are normal, and they have no bizarre delusions, non-bizarre delusions. تمام? And more than 50. Do they have hallucinations? No. They don't have hallucinations, no memory loss, but they don't have Alzheimer or dementia, and they're not related to any of the drug use. طيب. One thing I actually forgot to mention in schizoaffective disorder is the period of mania and depression and the periods of psychosis. So it's usually more than one periods of occurrences of depression and mania, plus 2 or more episodes of psychosis for more than 2 weeks. This is diagnosed as schizoaffective disorder. تمام? A single episode, more than one at least episode of depression or mania, plus more than 2 episodes of psychosis for more than 2 weeks. All good. And we're done with schizophrenia. Now we have 5 questions. And خلاص, we're done with today's crash course. So Let's say this patient, he has dirty, unkempt appearance, suggests which one of the following. طبعا this one is sort of unrelated, but try to remember it because it's a commonly asked question. Schizophrenia only. It could be dementia. It could be schizophrenia. It could be homelessness. And it could be alcohol and drug addiction. So it's all of the above. It's any of them. تمام, remember it because it's a common question. طيب. A 23-year-old male brought by family to the hospital with a history of gradual onset of suspiciousness, paranoia, isolation, violent outbursts, and lack of interest in his studies. These symptoms have been going on for over 6 months. He denied any drug use. Mental state examination revealed a sad mood with that effect, thought, broadcast, and impaired judgment. He is most likely suffering from which one of the following conditions? Typical sign of schizophrenia. And we said if it's schizoaffective, I meant schizophrenia form. If it was schizophrenia form disorder, it would have been between how many months? 1 to 6 months. Perfect. So, what is a favorable prognosis in schizophrenia? Remember, fresh, yes, sudden onset. Fresh risk. طيب. Finally, cognitive deficits of schizophrenia manifest themselves in which of the following phases of the disease? All phases of the disease. Yeah, if you remember this question, this slide, where we said in the cognitive is in all phases. Come on. Yes, and that's it for today's crash course. There was also some slides that spoke about the defense mechanisms. I'm going to cover them in tomorrow's crash course, inshallah. All the defense mechanisms and the ID, ego, and superego will all be covered together with the rest of the lectures in tomorrow's crash course. And thank you all for joining. Here's the QR code for feedback. If you have any questions, feel free to text me. And have a great night. That's it.